All right. So welcome everybody to our presentation today about acute pain management in an area of opioid use disorder. In case you have never met me before, I am Alicia Gonzalez. I'm an emergency medicine physician. I work here in California, and I'm also the director for clinical training at the California Bridge Program. If you are not familiar with us, the California Bridge Program is a program that falls underneath the Public Health Institute. We are a publicly funded organization. We don't work with any pharmaceutical companies. And today's presentation is actually being funded and brought to you from the California Department of Public Health. They are an amazing partner of ours. We're so excited to be supported by them in doing this work. And as I mentioned, we do not have any financial disclosures. We do not have any relationships with any pharmaceutical companies. However, as a practicing emergency physician, I probably will slip and say a brand name here and there. Please do not misinterpret that as loyalty to anybody. But sometimes, our patients very commonly use words like, for example, they'll say Narcan instead of naloxone, right? And so sometimes we slip and we say Narcan because that's what we're used to hearing from our patients. But it's not meant to be any financially driven comment. If you haven't heard of us, as I mentioned, we here at California Bridge have one goal, and that goal is to make high quality treatment for substance use disorders available in every hospital across California by 2025, which is next year, in case you're counting. So far, we are almost there. We're at over 280 hospitals, which is getting so close to all of them here in California. But why are we doing this? Why is that our goal? Why is there a whole organization aimed at doing this work? And the answer is, and I'm sure you've seen this before, the answer is because substance overdose is becoming or has become one of the leading causes of death of people all across the country, but especially here in California. And you can see on this graph that it's not just opioids, it's a lot of other drugs as well. It affects men, it affects women. And why is this something that we didn't talk about maybe when you were in residency or back when a lot of us were training in healthcare? If you look back at 1999, look at that. Less than 20,000 people died of substance overdose, less than 20,000 across the entire nation. But as of now, it's over 100,000. That is a five-fold increase in that amount of time. And so now it's this leading cause of death and something that we really have to address. But there was an education gap for many of us because it wasn't one of the main priorities back when we were all learning. If you look at why people are dying, like what substance is killing them, you can see that synthetic opioids, which means fentanyl, the purple line, fentanyl, is number one. It is definitively the number one killer because it is so potent and it's really like laced in everything. So we have a lot of unintentional overdoses from opioids for people who are trying to use stimulants like methamphetamines, for example. We're still definitely seeing, though, some methamphetamine and stimulant-related death. That's the blue line. And then cocaine, still out there and active. That's the greenish colored line. And then still prescription opioids is that yellow line. So it's still not gone. People are still dying on pills too, which if you're somebody who thought maybe the solution to all of this was that we should just curb our prescribing habits, we should stop prescribing opioids for people, and that would work. Unfortunately, that is an important part of it, but it didn't work. You can see here that I mentioned, right, the death rate started to skyrocket. So back in 2010, we started seeing lots of efforts to decrease our prescribing. And you can see that purple bar in the bottom part of this graph, shrinking, 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 coming up to 2020. We have been decreasing our opioid prescriptions, doing a better job not using opioids to treat all pain. And that's a good thing. But the death toll is rising, right? So we're seeing the blue bar still continue to go up. People are still dying. And the main reason, again, is because of fentanyl. But I want to emphasize that not exposing people to opioids who don't need to be exposed to opioids is still going to be part of a comprehensive solution to this problem. Like with any lecture we ever give, we really want to make sure we always emphasize this point, which is we cannot do this work if we do not accept that addiction is not a moral failing. It is a chronic, treatable medical disease. It is a neurocognitive brain process, and there are medications that can help our patients discontinue or improve the safety of their drug use. It's similar in the way that people have, say, diabetes, right? People make unfortunate health choices or they have genetics that predispose them to things like diabetes. And so we give them insulin or metformin or medications to manage their blood sugar. This is the same. People make specific choices on how to, cope with stressors in their life. Maybe they have genetics that predispose them to things like addiction. And now we have medication to help people to discontinue using drugs. So it's really important that we see it as a medical issue, because the stigma that has existed in the House of Medicine has not helped us do a very good job for our patients in the past. And from that belief came the California Bridge model, which now we have implemented and helps to implement all across the nation. It's not just ours anymore, and we love that. But there are three main pillars of this work. Number one, low barrier access to that medication treatment. If people can't access the medications, they're not going to get them or take them. So it has to be low barrier. And for us, that means in the emergency department, in the hospital, in the clinic, wherever the patient shows up, we want them to be able to access care today, right now, not get a referral for 2 months from now, but low barrier, start it now, access to medication for their addiction. The next thing though is, it's the ER and the hospital's job to stabilize our patients, but we are not a long-term addiction management specialists. We want our patients to get outpatient ongoing supportive care, which is the right place for them to be doing that. But it's a really complex system that's extremely hard to navigate. And so we are very proud of our army of navigators that exists here in California. But the idea that you have to have a connection to that ongoing outpatient care. So low barrier access to care with a warm handoff, clear, definitive assistance to get patients into the outpatient setting. And then finally, building a culture of harm reduction. For us, that actually means two things. One, shifting our mindset away from the stigma-ridden approach that we used to use for patients who use drugs into a much more, modern understanding of the actual neurocognitive processes so that we can get rid of that stigma and help our patients. But the other piece has to do with having really candid, honest conversations with our patients about drug use and how to mitigate the risks, the morbidity, the mortality associated with using drugs. And that's actually kind of what is going to bring us into this conversation today. I want to quickly breeze through a little bit about treatment for opioid use disorder specifically. If you want a deep dive on this, though, this is not the lecture for you. We're going to incorporate, though, talking about patients who are on buprenorphine or methadone into this lecture. So I do want to make sure, in case you're not super familiar, that we have covered some of the basics. There are multiple medications for opioid use disorder specifically. We call that MOUD, or meds for opioid use disorder. Methadone, a full agonist on that opioid receptor, turns it all the way on. Very effective medication. We are not here to knock methadone, not at all. Naltrexone is an antagonist. We don't love this medication for opioid use disorder. It's really good for alcohol use disorder. Not our favorite for opioids. The evidence isn't quite as robust and positive as it is for methadone and buprenorphine. And hence, we're going to focus a little bit on buprenorphine. So why do we love bup? Bup is only a partial mu agonist. So instead of turning that receptor all the way on, the way that morphine or hydromorphone or hydrocodone, oxycodone, and methadone do, it only turns it part of the way on. So there's no ceiling on treatment level. You can give buprenorphine at very high doses to help with cravings, withdrawal of opioids. However, there is a ceiling on respiratory depression. So at very high doses, or as you go higher in doses, full agonist opioid can cause you to stop breathing, but buprenorphine by itself will not do that. So we love that for practical and safety profile purposes. It has a nice long half-life at about 24 to 36 hours. So patients who are using buprenorphine specifically for opioid use disorder, they can take it once a day, maybe twice a day, depends on the patient how they want to take that medicine, but it's very practical for them. They can also take a prescription home. You as the clinician don't need a special license. Like if you have a DEA and you can write for hydrocodone, you can write for buprenorphine, whereas methadone has to come from an opioid treatment center. There's a lot more rules and regulations that govern that. So it's nice for us because bup is just really practical. It's really easy for the patient. They can go home with a prescription. It has that ceiling on respiratory depression. And so we love this medication. What we know is that patients who are chronically using full agonist opioids, who have opioid use disorder, that their likelihood of death is 6 times that of the general population. This is a very, very high risk medical condition. But if you get that patient started on buprenorphine or methadone, so if they're on medication for their OUD, their risk of death comes down to less than 2 times that of the general population. So that mortality reduction is one of the most powerful mortality reductions provided by any medication literally that exists in modern medicine. We know that it works. And kind of said another way, if you look at patients who are currently in methadone treatment or in buprenorphine treatment as opposed to coming out of their treatment, you can see the mortality risk, the size of those columns, it shrinks immediately once somebody is in treatment with methadone or buprenorphine. So we know these medicines save lives. It's way better standard of care than a lot of things we consider standard of care. I mean, look at this number of people that you have to treat to save one life. 42 patients must get aspirin in the setting of an ST elevation, myocardial infarction, or a STEMI, a heart attack. And only 2 people started on buprenorphine who have opioid use disorder. You'll save one of their lives. 2. That's a 50% success rate. Again, one of the best medications that we have out there. For all of us who are on this lecture today to understand how to better treat pain for patients who are on MAT, one of the reasons that that is important is that this is a chronic medication for people. It's not something that we want to force patients to taper off of or to, withdraw from, if you will, eventually. No, these are supposed to be chronic medications. We don't tell our patients who start insulin, maybe someday when we feel you're ready, we're going to make you taper off of insulin. Does that mean some patients will eventually come off insulin? Yeah, they actually will. They'll be able to lose weight or, get it under control in different ways with their diet and come off insulin, and maybe they use metformin. So will some patients come off of methadone or buprenorphine? Yeah. But will the majority? No. Their body composition, their physiology has changed. They need this medicine to feel normal. And so the goal is to keep people in treatment, not to force them off. And we know that if you force people off of their long-term MAT, that they actually don't do well and their risk of death goes very high. So for that reason, we have to take a different approach to thinking about pain management. This lecture is going to focus mostly on pain management in the acute setting. So that'll be true for a primary care provider for a patient who has like an injury or acute pain and they're coming to you and they're on MAT, but also in the ER or in the hospital. That's the angle we're going to take. We'll do chronic pain a different day. That's its own very, very detailed and deep dive kind of conversation. This is more acute pain. But what we have to do when we think about pain management is make sure that we all have the same goals, which is going to be looking at both medication and non-medication interventions. So we'll talk a lot about that. We want to make sure that we're using non-opioid medications as the first line treatment for mild or moderate pain. So gone are the days in which morphine, hydrocodone, oxycodone are the first line for ankle sprains and mild fractures that have been stabilized in a splint and migraine headaches. That's wrong. We don't need them. We know that other medicines are very effective and we don't need opioids. So they should not be the first line treatment. But we do, of course, want to continue using opioids as the amazing tool they are as second line or breakthrough rescue medication for patients, but also used for acute severe pain, right? Things like a heart attack, things like breaking your femur, things like, polytrauma. We have lots of patients who certainly will need opioids. And I'm not saying that we don't ever want to use them. We just want to use them on purpose and be really smart and selective about that. When we think about treating pain, one of the reasons we move away from opioids is we want to think about targeting multiple pain receptors. The mu receptor, the opioid receptor, is not the only way that our body perceives pain. And yet, we just sit there in medicine a lot and we smash this mu receptor, hoping it'll do a good job. But if we take a multimodal approach and we look at the different ways our body experiences pain, and we give a medicine over here and a medicine over here and a medicine over here, we can do a way better job of comprehensively addressing pain that way. Mentioning that harm reduction column, right? Being more comfortable talking about drug use with our patients. The same is true with being more comfortable talking about pain management. What are the goals? Be realistic with your patient and talking openly about the potential for addiction and side effects when you are going to use opioids. We want to educate our patients on a stepwise, holistic approach to pain. What do you do when you're in pain? And the answer is not reach for your bottle of hydrocodone that you have at home. That's not the right answer. And so how do our patients go stepwise on their road to pain management at home? And then, of course, continuing and prioritizing medication for addiction treatment for our patients who need it and not making them come off of it. So to do this, we have to take a multimodal approach to attacking patients' pain. And so I'm going to walk through a handful of some of my favorite medications and how you can use them in pain management. Now, some of this will obviously be very basic and review. However, we're going to talk about some basic medicines because I think a lot of times our patients will say, quote unquote, that medicine doesn't work for me. And we forget that we're the clinician. It's our job to reset the patient's expectation and talk about why these medicines that maybe don't work for your chronic pain or maybe don't work for your opioid withdrawal pain will work right now for your ankle sprain or will work for your rib bruise or will work for whatever it is that you have right now, your headache, your viral syndrome, etc. Acetaminophen, okay? Don't knock acetaminophen, right? Most common over-the-counter name is going to be Tylenol. So when our patients talk about that medicine, acetaminophen or APAP is the abbreviation we like to use in medicine. This medication works in the COX pathway, so the COX inhibition, and it does not actually do very much anti-inflammatory. That's more for our NSAIDs, hence the anti-inflammatory part of that name. But for acetaminophen specifically, a lot of times patients will say it doesn't work for them because they're underdosing. Patients can take 500 milligrams. They can take 1,000 milligrams. You can take a gram of Tylenol at a time, up to every 4 hours, but you're going to max out at about 4 grams in 24 hours. Or if somebody has liver disease, right, 3 grams, kind of back it off. But they can take a gram at a time. So a patient who took a single over-the-counter 325 milligram acetaminophen may not feel anything, but if they take that full 1 gram, they might. And so remember that. And then what we know also is that there is IV acetaminophen out there. I think a lot of us love this medication, especially for fractures. Whether your anecdotal experience wants to believe this or not, there have been multiple trials that have shown that IV versus PO treatment with acetaminophen is equivocal. So believe it or not, your favorite IV 1 gram acetaminophen works the same as oral. Now, there are lots of times where we might want to use the IV one because patients can't tolerate oral. Maybe they have a fever and they're altered or something like that. And so there are definitely times where we need that IV version, but IV is equivalent to PO. It's a really amazing medicine. And so please don't forget that just because it's over the counter doesn't mean it's not effective. It's actually a really good, important piece of the overall treatment for our patients. Okay. Second big player that these are like going to be our first 2 medications in almost every single pathway we talk about today. But NSAIDs, non-steroidal anti-inflammatory medications. These also have COX inhibition, but unlike acetaminophen, they do have anti-inflammatory effects in the peripheral system, which is great. There are some contraindications with these. So with acetaminophen, there really is none except for straight up allergy. Even patients with liver disease, you can just back off on the dose, right? With NSAIDs though, patients who have CKD really shouldn't be taking NSAIDs, the chronic kidney disease. That said, patients who have end-stage renal disease, what are you worried about? You know, like ruin their kidney? They're on dialysis. It's okay for them to occasionally get an NSAID. I probably wouldn't pummel them with it, but if they have an acute injury, it's not going to ruin anything. They're already on dialysis. They can have ibuprofen here and there. People who have a lot of gastric ulcers or peptic ulcer disease, especially if it was caused by NSAIDs, we try to avoid NSAIDs. Patients who've had gastric bypass surgery shouldn't be taking NSAIDs, routinely, but if you're seeing them acutely in the hospital, there's a very low risk to doing a single dose in the emergency department, IV or IM, say of ketorolac. It's a reasonable thing to do. And then for patients who are on anticoagulation, NSAIDs have antiplatelet properties. So we don't want to like double down chronically on thinning out their blood, right? We can definitely make it more dangerous for patients who are on something thinning their blood from, say, a heart attack or stroke history, and now we're adding an antiplatelet agent. That said, I will remind you that plenty of patients are on anticoagulants and aspirin as a baseline and clopidogrel as a baseline. So there are patients that are on antiplatelet and blood thinning agents. So if your patient's on a blood thinning agent and they're not on an antiplatelet agent, it is reasonable for them to use a short course of NSAIDs to help with their pain. We just have to do a good job of talking to them about fall precautions and those kinds of things, which are going to be really similar to what you would tell them about their blood thinner anyways. Again, I want to emphasize that just because it's over the counter doesn't mean it's not effective. NSAIDs are super effective. The ceiling analgesic property, though, like the ceiling analgesic effects for ibuprofen, 400 milligrams. That's the over-the-counter dosing, 2 tablets, 400 milligrams every 6 hours. We do not need to be writing prescriptions for 600 and 800 milligram ibuprofen. It does not work better. That is exceeding the analgesic ceiling. There is some added anti-inflammatory benefit at those higher doses, but there are also an increased number of side effects and of GI upset experienced at those higher doses. So my recommendation for you would be try a single 600, maybe 800 milligram dose while someone's with you in the emergency department or in the hospital, but they shouldn't be going home with prescriptions that high. They can absolutely do 400 milligrams every 6 hours. Of course, by the way, these are adult size dosing. Pediatrics are going to be weight-based. You can also try naproxen, which is 500 milligrams twice a day. I personally have noticed that my patients tend to like being on ibuprofen. Number one, it's really cheap and inexpensive, which is great, but they also tend to prefer to be able to take it every 6 hours instead of only every 12 hours, but naproxen is another option. And then when someone's with you in the hospital or the ER, you can try ketorolac, right, the injection version. The ceiling for that one's actually going to be 15 milligrams. Patients do not experience more pain relief at 30 or 60 milligram doses. But again, we do see higher rates of side effects. So the cap on your ketorolac dosing, 15 milligrams. More recent literature is actually showing us that maybe even 10 milligrams might be the analgesic ceiling. So I recommend 10 to 15 milligram doses. Please, gone are the days of the 60 milligram dose forever. And most patients don't need 30 milligrams either. So 10 to 15 milligrams IV or IM is great. And then don't forget topical. You can put diclofenac gel, which is an NSAID-based gel, directly onto items that hurt, especially for musculoskeletal pain. And that can be another effective way to do that. What's amazing about acetaminophen and NSAIDs is that there have actually been quite a few studies looking at the synergy between these medications. For example, there have been multiple post-operative and dental pain-based studies where they looked at ibuprofen alone or ibuprofen with acetaminophen. And what they found is that patients who got 400 milligrams ibuprofen with 1,000 milligrams of acetaminophen had better pain control than those that just received the single agent. So we do see some synergistic effects in their ability to control pain. There also were two very large, robust, really good studies in JAMA a couple of years ago. It's the Journal of the American Medical Association, looking at back pain. What they looked at was naproxen alone, so an NSAID, versus naproxen with oxycodone. They also looked at naproxen alone versus naproxen with diazepam, common brand name would be Valium, so a benzodiazepine. And what they found is that patients with naproxen alone had the same amount of pain control and pain relief as those who had an added opioid and those who had an added benzodiazepine. So the conclusion here in these very robust and very good studies was that adding the benzo and adding the opioid did not actually improve pain control. It did not. It was not necessary. And so there's a lot of literature out there that shows that we're just prophylactically giving opioids when we actually don't need to. Okay, this is one of my favorite medicines to teach people about because I don't think that we're utilizing this one enough, especially in the acute care setting. And this is going to be IV lidocaine. This actually came to us originally from a couple of places. One is that over in the Middle East, there are a couple of countries that do not have injectable NSAIDs. And so they were really interested in trying to find a medicine to help with renal colic that wasn't just morphine. And so they did studies using IV lidocaine, and what they found is that patients who received doses of IV lidocaine instead of opioids had the same amount of pain relief with fewer side effects and shorter time to discharge than patients who got the IV morphine. So, and they were giving morphine, by the way, at really solid doses, like 6 milligrams and higher. So it wasn't like these, like, smaller doses. But this medication worked. We also saw a lot of examples in the oncology literature. So patients who are already, say, using chronic opioids or other medications, and they use IV lidocaine perioperatively, or they use it for breakthrough pain for patients who are admitted. They have a lot of success there. And then the postoperative literature, especially patients who got abdominal surgeries, what they found is that patients who got IV lidocaine had a faster return to bowel movement, which anybody who's ever rotated on a surgical service knows how important that is. And then also faster times to discharge, faster times to ambulation, because IV lidocaine doesn't slow the gut. It doesn't cause constipation for our patients or ileus. So this is a really good medication. The way it works is you give 1.5 milligrams per kilogram to a maximum of 200 milligrams. That's the max dose. You can do it on a pump. You can do it as a slow push. The doses are here on the slide for you. What I would say is if you want to do this, make sure you work with your pharmacy at your hospital and with your nursing director so that the pumps in your ED actually have a setting where they can like hook up the IV lidocaine and it can run appropriately. So that's not a hard thing to do, but it takes a little bit of effort. It's hard for a nurse who doesn't have that set up to be able to do this comfortably. But it's a very easy thing that you can do. You can repeat this dose one time after 90 minutes. And then the literature has never shown any increased cardiac arrhythmia, dysrhythmia, or side effects. This is very much lower than the cardiac doses that we're using in ACLS. This is definitely way lower than the toxic dose, which is about 5 milligrams per kilogram. So we're not really worried about cardiac dysrhythmia or dysfunction as a side effect of this. However, most hospitals do have a protocol that patients receiving IV lidocaine should be on a cardiac monitor for about 30 minutes. And I think that's a very reasonable recommendation. For patients who have reduced hepatic flow or who are older, especially over 65 years old, we tend to recommend starting with a half dose. You can always repeat it, right, in 90 minutes, but it's just smarter to kind of back off. And then we don't want to poke the bear. So even though we've never seen, severe side effects from IV lidocaine that are cardiac in nature, if somebody has a known, structural or occlusive cardiac disease, we do recommend maybe this is not the right medicine for that patient. And then patients who have a seizure history that's active, lidocaine will lower your seizure threshold. And so we don't really want that to happen. And obviously patients who have a lidocaine allergy shouldn't be getting IV lidocaine, but this is a great medication. There are studies that show, I mentioned this, but incredible effectiveness in renal colic postoperatively. I love it for acute chronic pain, like abdominal pain, even back pain. And sometimes I've had patients that were signed out to me that got, hydromorphone multiple times. I gave IV lidocaine, and all of a sudden they feel better. So it's attacking a very different receptor pathway, very successful medication. You can also use lidocaine topically. So don't forget the skin. We often forget about, the topical ways we can do things. There are patches, there are creams, there are gels, there are ointments. A lot of them are over the counter. So it's also an affordable way for our patients to be getting this treatment. In more recent years, we've been seeing manufacturers put out lidocaine with concentrations higher than 5%. You do not need that. And in fact, that's too much. Patients might unintentionally overdose on lidocaine that way. So please don't use anything higher than 5%. There are prescription patches. I will tell you that studies have shown that the over-the-counter patch versus the prescription patch, their efficacy is similar. The difference is that the prescription patches tend to have a nicer adhesive. So if I have a patient where the patch is not covered by their insurance, I often will just tell them, hey, the over-the-counter one, which are about $1 or $2 a piece if you buy them in a box at any random pharmacy or big box kind of store like Walmart, Target, whatever, they're about $1 or $2 a piece. And I just give them a roll of tape, like the tape that we use to paper tape in the hospital. So I just say, hey, the stickiness may not be very good. Here's some tape for you, but the medicine will work the same. So that's really helpful to know. All right, next medicine, muscle relaxers, which is a major misnomer. These medicines do not relax muscles. So I want to be very clear. They're called that. That's not how they function. They actually relax the CNS, the brain. They help people feel calm. So they're a person relaxer. They have no direct action on the actual muscle tissues or the muscle fibers or any of those bonds that cause, muscle spasms. And there have been multiple studies that have shown no additional pain control when you have a patient who is given NSAIDs versus NSAID and a muscle relaxer in musculoskeletal or back pain especially. So multiple studies have shown that when you add that muscle relaxer, it doesn't do anything. What I would say though is there is a role for using a person relaxer like this once in the acute care setting. If you have somebody who's had the kind of pain that has kept them from sleeping, right? We have two big categories of pain. Nociceptive pain, meaning pain that you feel because of the receptors in your body feeling the pain. And then we have non-nociceptive pain, which is also real, but it is our body's more emotional, psychological, etc. response to pain. And both of those are really important to think about. And when patients have, say, back pain is a great example, or a spasm in their neck, and they've been unable to sleep for multiple days, now their pain feels even worse. Subjectively, they are feeling worse pain because they are tired and they haven't slept well and they are not relaxed. And in those patients, giving a person relaxer, or in my opinion, a single dose of benzodiazepine to facilitate sleep and calm can be a really helpful adjunct to the other medications we're giving. But it's important that you know why you're doing it, that you're giving that medicine to relax the person and that you are not prescribing it to go home. These medications cause CNS depression. Like I mentioned, it makes people feel sleepy, woozy, confused. They are not supposed to drive a car. They are not supposed to operate heavy machinery, those kinds of things. And they have been shown to have addictive properties. So we don't need to be sending patients home with these prescriptions. It has other side effects we don't want to deal with, but a single dose can help to facilitate calm and sleep for that patient. If your patient has any neuropathic sounding pain, so great examples of this, patients with gastroparesis who got the burning feeling in their abdomen, patients who have sciatica or radiculopathy and they feel the burning in their hand, their legs, diabetic neuropathy, etc., they can actually get gabapentin. So this is a medicine that can be used in the chronic setting. When you do it that way, it has to be titrated up and titrated down when patients start it and they come off of it. And that's because of just the effects over time. They'll have really bad side effects if they take a higher dose immediately for a long time or multiple days. And if they suddenly come off of it, patients can get those side effects. And that includes things like, feeling dizzy, feeling unsteady, lots of nausea and vomiting, headaches, vertigo. It's pretty uncomfortable. However, a single dose in the acute setting of somewhere between 300 and 600 milligrams, not going to cause those side effects. So you are totally safe to give a single dose of this in the ER, or even if patients wanted to have it on an as needed basis and they're not taking it more than once every couple of days, it is safe for them to do that. So again, chronic usage and every day for things like peripheral neuropathy, we got to titrate up, titrate down. That's up to a primary care clinician to help them manage. But in the acute pain setting, if it includes nerve-related pain or that burning sensation of pain, you can give a single dose of gabapentin, which works really well. And that's going to act on the calcium channels to inhibit excitatory pro-inflammatory neurotransmitters. So now we've talked about inhibiting the COX pathway, both centrally and peripherally. We talked about using lidocaine to kind of numb our sensory receptors. We talked about calcium channel blockers. So the goal is, again, multimodal. And now shifting to our NMDA receptor, ketamine. There is not a single emergency department clinician out there who does not have a small, at least a slight affinity for this medication. We love ketamine in the emergency department. This medicine is great because, again, we don't really have a lot of medicines that work on the NMDA receptor specifically. So usually it's just like wide open, sitting there waiting for us to do something with it. And it does help with analgesia, with relieving pain. Ketamine works on a dose-dependent scale, and it's a really interesting medication because depending on the dose, you can get really different effects. This is kind of what that looks like. So we use ketamine a lot for full sedation. That is the 2 milligrams per kilogram IV or 4 to 5 milligrams per kilogram intramuscular. That's full sedation dosing. That's dissociative dosing where the patient is like not really anymore fully aware. We use that for procedural sedation in the emergency department. That's not the dose that we're talking about here. We're talking about a much lower dose, 0.1 to 0.3 milligrams per kilogram IV to a maximum of 30 milligrams. This is a pain control dosing. There are doses in the middle, which you absolutely want to avoid. We like to call that the K-hole, the ketamine hole, and that's the more recreational drug use. You can see people get really agitated and angry and delirious, and that is not the zone that we're trying to use. So we're either using ketamine for full dissociation, as in sedation dosing, or in this context for pain medication, 0.1 to 0.3 milligrams per kilogram IV. You can also give this medication intramuscular, 0.3 milligrams per kilogram. You can do it intranasal. You just split the dosing between the two nares. You can actually start people on a ketamine drip, believe it or not. And probably that's not going to fly in most hospitals on your like floor, maybe your ICU. But if you have a patient where you gave, a dose of ketamine and an hour later it worked for them, but it wore off, you give another dose that works well for them. Sometimes those patients with acute pain flare, if you put them on a ketamine drip in the emergency department for a couple of hours and then you titrate the drip off, they feel better. And then you saved an admission for intractable pain. So that's a really good use for it. It'd be a little bit more prolonged ED stay, but it might save an unneeded admission. And it's a really good option. Again, ICU teams are normally better equipped to handle that as well. But you can do it at 0.1 milligrams per kilogram per hour. And that can be really helpful if a patient's responding well to multiple repeat single doses of ketamine. You don't have to have a cardiac monitor. That is a very common misconception about ketamine. You don't have to. Obviously, every hospital's protocols are going to be different, but the evidence does not suggest that you need that. And the main side effect that we see is what we call altered sensorium. People can report a feeling of kind of like being a little bit out of their body. Some people report the same thing, like when they take pseudoephedrine, this feeling of just kind of like being out of their body, but it's not full dissociation. It's not quite the same, or like that, those wake up issues that we see sometimes after a ketamine sedation. It's not like that. It's just kind of this feeling of like, my head is a bubble. I'm kind of out of my head. And that's the main side effect that we see. So it's not dangerous. Now, I want to talk about steroids for a second. Evidence has shown us over and over that steroid bursts don't work for most of the ways that people get pain. So like the Medrol dose pack for back pain, as a great example, please stop doing that. Evidence does not support that. It doesn't do anything. However, dexamethasone specifically, so specifically Dex, 10 milligrams IV, you can also give an oral dose of this. Dex actually has a specific analgesic effect. It works as a pain medication separate to how it works as a steroid. So I'm not advocating for use for steroids in a bunch of these patients, like prednisone, prednisolone, solumeterol, not those medications, but dexamethasone specifically. It does. And its mechanism of action is going to be through the phospholipase inhibition, which is going to decrease pain from your COX and lipooxygenase pathways. So again, pathways I haven't mentioned lipooxygenase yet today, right? So it's another way to add multimodal analgesia. This is particularly helpful for patients who have neuropathic pain and also for patients with migraine headache. Evidence has shown us that patients who have rebound migraines, who get a dose of dexamethasone in the emergency department, have lower rates of 72-hour bounce back to the ER for headache. So it's really good at helping with things like, neuropathic pain, migraine headaches. And so again, not short course outpatient steroids. We're not advocating for that. This is a single dose of Dex as an actual pain medication. Let's practice with a few cases to see if we can make this feel a little bit more practical. And for those of you who are watching live, feel free to throw your thoughts into the webinar chat. I'd love to see if you beat me to the punch on any of these. But here's your first patient, Javier A. This is a 33-year-old gentleman. He does not have any past medical or surgical history, generally healthy guy. He was moving some furniture with a friend. Oh, he hears a pop and he feels some severe sudden pain in his low back, and it's like shooting down his left leg and feels like it's burning. When you do your workup and your physical, you're not finding any red flags. For all my clinicians out there, I'll just summarize for you. No red flags. Maybe you did some plain films or not. That's up to you, but negative workup in general. But this poor guy, his pain is 10 out of 10. He's not able to sleep. He's absolutely miserable, hurts to walk. What do you do? How can we control Javier's pain? All right, I'll give you the answer. So for atraumatic back pain, our first line is going to be a combo of a lot of the medicines we said. You're going to give that full gram of acetaminophen, add an NSAID, whether that's 400 milligrams oral or 15 milligrams IM ketorolac. That's my go-to. I am almost always giving ketorolac in the emergency department. I think patients appreciate the injection dosing, to be honest with you, and it really does have a nice fast onset. Because this guy has really bad neuropathic pain going down his leg, he's a great candidate for a single dose of gabapentin between 300 and 600 milligrams oral one time. And I'm going to apply 1 to 3 lidocaine patches anywhere on his low back or wherever that pain is that he's feeling. Let's say that doesn't work, though. What could we do next? Well, now you're going to have to get him into a bed and out of your lobby. But maybe because he hasn't slept in several days, he's a good candidate for a person relaxer. I personally use diazepam 5 milligrams oral. That's my typical. If it's an elderly person, I back off to 2 or 2.5 milligrams. If you're somebody who prefers, muscle relaxer as your person relaxer, that's also totally reasonable. Baclofin's one example. There are many, many muscle relaxers out there. This patient would be a great candidate for a single dose of dexamethasone, and we can also use ketamine. So we have lots of options there. If the patient's exam is consistent, you can also consider what's called a trigger point. So when you're examining your patients and they have musculoskeletal pain, sometimes, or like if you've ever had a massage and the therapist is like rubbing or you're rubbing the patient and you feel that like thunk and the person goes, ah, that's a trigger point. Trigger point is just a fancy way of saying, like a muscle spasm or a very tight muscle knot. But what we know about trigger points is that they recruit the muscle fibers around them. So people will say like, oh my gosh, my whole neck or my upper back hurts. And as you rub them, maybe right here in their upper trapezius, you bop this muscle knot and they're like, oh my gosh. So all that pain is actually recruited friendly muscle tension because of this one muscle knot. And so what we have to do is mechanically disrupt those bonds. So similar to an abscess where the blood flow is not really going through the pus, right? You have to cut it out and get that pus out. There's no other way to get there with antibiotics. This is similar. Trigger points are very, very tight knots. So think about how they're squeezing and not really allowing blood flow of your medications. We got to mechanically disrupt that intensity. To do it, it's so ridiculously simple. I do this in my lobby all the time. It's one of my favorite procedures to do. All you need is some lidocaine, a syringe, and a needle to pull up your medicine and a needle to inject it. So an 18 to pull it up and something like a 25 or a 27 to inject it in your patient. An alcohol pad to wipe the top of your lidocaine before you draw it up and to wipe their skin before you inject. And then you're gonna need a Band-Aid. That is it. This fits in my pocket. I actually often have it in my pocket when I'm going to see somebody with back pain just in case. And what you're gonna do is you're gonna use your fingers, you're gonna find that knot, you're gonna hold it with your finger. You're gonna clean that space with an alcohol swab. You're going to inject a wheel of lidocaine because you're about to put a needle in this person. So it's going into their skin, their subcutaneous tissue. Then you're going to take your needle and you're going to inject it straight into the middle of the muscle knot. You're not going to inject any medication here, okay? The work is actually being done by the needle. Acupuncturists and physical therapists in certain states can do this. It's called dry needling. It's the same thing. We just have the benefit of being able to put lidocaine in there at the end to help with the pain that we have caused from the dry needling. But the needle goes into the muscle knot. You're going to pull it almost all the way out, re-angle, go back in. Pull almost all the way out, re-angle, go back in. You're going to make kind of a star, a sun shape going through that muscle knot, trying to break up mechanically those tight bonds. Sometimes when you do that, you will see the muscle jolt. That's okay. Don't freak out. Totally normal. You did it right. That's like a pathognomonic finding, actually. If it doesn't do that, it's okay. But you do that maybe 5, 6 times. Then you go back in the middle. And as you pull out your syringe, you're going to inject maybe 1 cc of lidocaine as you're leaving. And that's, again, to provide some pain relief from the fact that you just jabbed a needle all around. So the work is being done by the needle, and you are giving lidocaine to support the pain that you have caused. So I want to be very clear about that. But this is a billable procedure. It's called the trigger point injection. You can put this as a procedure into your note if you're a clinician, and it works really, really well. I will do this, then give my patient acetaminophen, an NSAID, slap a lidocaine patch on top of there. And by the time we've given all those medicines, normally the patient is moving a lot better. This is great in the low back. You can actually find them in the anterior thigh. Anywhere you can find a tight muscle knot that you can put a needle into, this is a reasonable thing to try. And it's very safe and very easy to do. Let's adjust Javier's story really fast and say that instead of it being what he was before, he's still a 33-year-old man. Now his name is Javier B, but he does have a past medical history of kidney stones. Now he's got 10 out of 10 right flank pain. It goes into the groin, maybe a little bit in the butt, but mostly into the groin. He's been vomiting, but he doesn't have a fever. His labs look great. His kidney function's okay. His urinalysis has blood, but no infection. You do a bedside ultrasound because you're an amazing emergency clinician who knows your ASAP choosing wisely guidelines. He doesn't need a CT scan. He's got no hydro. And so your main focus here is pain control. What can we do for Javier B? The beginning is going to look really similar, right? So we're going to add acetaminophen, add that NSAID, obviously give fluids. Our kidneys love fluids. It's a really important part of it to dilate up those ureters and help those stones pass. And then you're going to add whichever antiemetic is of your choice. They're all kind of equivocal in this setting. But your second line medication is going to be IV lidocaine, 1.5 milligrams per kilogram IV to a max of 200. Totally think about ketamine. And then, of course, if none of this is working, it's super reasonable to consider opioids. So I'm not saying we can never give opioids. However, I will tell you that I honestly cannot remember the last time I gave an opioid for kidney stone related pain, even for obstructing stones, because I personally use this algorithm. And I've been practicing for over 10 years. And I use the lidocaine a lot. It's really effective. But of course, you could use opioids if none of that was working. Or, for example, if you don't have access to lidocaine. Speaking of antiemetics, I want to deep dive into that a little bit more because a lot of times we all reach for ondansetron, common brand name being Zofran, for our antiemetic of choice, and that's totally reasonable. However, depending on what the patient is here for in the hospital or in the ER, there are other antiemetics that have secondary effects that may benefit that patient. So it's important for us to think about that because we might get a double whammy if we switch our medicine. So metoclopramide, really common brand name is Reglan, but metoclopramide is a prokinetic agent in the gut. It actually stimulates GI peristalsis. So if you have a patient who has an ileus, if you have a patient who is postoperative, somebody who's been constipated, those kinds of things, using a prokinetic antiemetic can be really helpful in those two ways. Prochlorperazine, or a common brand name would be Compazine, but this medication is also FDA approved as an anxiety medication. So when I see patients who are just really stressed, they haven't slept in days, they're like, maybe they're tearful and they're crying, all reasonable things because of their pain, I often will reach for prochlorperazine as my medication choice because I also know that it offers a sense of calm to that patient in addition to treating their nausea and vomiting. Haloperidol. This is an amazing antiemetic. We often forget about Haldol or haloperidol. 2 to 5 milligrams. You don't have to go super high dose on this one. You can give it IV. Some hospitals will require you to have a patient on a monitor or at least get an EKG to check their QT, which is a reasonable thing to do. But giving haloperidol, there I go, sorry, trying to say the brand name, but haloperidol, 2 milligrams IV can be a great antiemetic and definitely helps with that non-nociceptive pain, that like ratcheted up, anxious, not sleeping, sleep deprived, just really that kind of thing. It's also the #1 treatment for hyperemesis cannabis syndrome. So it's really important to remember that. And it can help facilitate common sleep. For metoclopramide, prochlorperazine, and haloperidol, we also would recommend that you add diphenhydramine to help prevent those extrapyramidal side effects. And so just be aware that if you're going to add diphenhydramine, that is sedating in some patients. So you may want to back off on your dose a little bit. So like I'll give prochlorperazine 5 and diphenhydramine 25 because I know that both of those are going to cause sleepiness. And I don't want to just like overtly slam people with the higher range of those doses. So let's talk about that. 50-year-old, the XY, they, them, this is Joey. And Joey has diabetes and gastroparesis history. They've had pain for like 5 years. They're currently in a pain management program, but they've been having a really terrible 2 days of severe gastroparesis style belly pain flare up. Joey has been trying home hydrocodone for the last 2 days, round the clock, sometimes throws it up, sometimes keeps it down, and it is not helping at all. You use some labs, they're fine. While Joey is very tender, you don't find any like severe acute peritonitis. You're not so worried about surgical process. Your now clinical gestalt is that this is acute on chronic pain flare. What can we do? And what I'll say is that because I mentioned that Joey already takes hydrocodone, and I could have said oxycodone, I could have said methadone, I could have said, oral morphine, whatever. Most people in that setting are like, well, this patient's already taking, hydrocodone at home. Grab the opioids. Like, this is silly. I'm not going to fight this fight. And in reality, that is 100% the wrong answer. This person has already been slamming their mu receptor at home, and it isn't working. Why would we then turn and try to just really slam again on that same receptor? Like, maybe we can just do it better. No, that is absolutely the wrong answer. And so instead, we want to think about this as an acute flare-up, right? Acute flare-up. And so patients will tell you that medicine doesn't work for me. You're right. That medicine seems to not work for your chronic pain. But today you're here with an acute pain flare. And so I want to try some other things. You tried this receptor. It's not working for you. I want to try all these others. And so I want to remind us that our goal here is to use non-opioids as first line for mild to moderate or acute on chronic pain, opioids as second line or breakthrough pain, and to optimize that multimodal pain receptor approach. And to do that, we must be able to talk about these things with our patients and educate them in a compassionate way. We certainly are not taking our time to do that enough right now. And the best way to do that is to first stop and establish realistic expectations from the very beginning with our patient. Chronic pain is horrific and really sad. And if I had chronic pain, I would be a hot mess. I'll be honest with you. I feel very fortunate that I don't. But it's also really not realistic to expect any clinician to be able to make somebody with chronic pain be pain-free. And yet our patients come to the ER, they come to you in the hospital, the clinic or whatever, and they do expect that sometimes. And that's not their fault. We have bred this idea into America over a long time. That's not the patient's fault. But it is our responsibility to reframe what we're doing to try to get the patients, their flare up back down to their normal tolerable level, to break crisis and bring them down to a functional level so they can fall asleep at night. They can get up and walk to the bathroom. They can watch a movie and actually laugh, right? Like things like that. So we really need to spend some time re-educating our patients. And if these are phrases that you're not super comfortable saying, I would recommend actually practicing them. Things like, I just want to be really clear today, Joey, like I can tell you're in so much pain and I really want to help you, but our goal today is not going to be to get your pain to zero. I wish I could do that. I wish I had that power. I don't, but I do want to move you from this intolerable pain in this crisis. I want to break that crisis and make that pain more tolerable. It is my job to keep you safe. I know that you said these medicines don't work for you, but opioids are really risky. And over time, they actually stop working. And I took an oath to keep you safe, and I refuse to do things that won't keep you safe. We have the same goal, which is to make you feel better, but I won't do it in a way that is not safe for you. For patients who have acute injuries, ankle sprains, wrist fracture, whatever, and they tell you like, well, it still hurts, but they're comfortable, they have good vital signs, right? All those kinds of things. We have to tell patients, I know it hurts, but that's going to hurt. You broke a bone, you hurt your back, you did whatever, and your body needs time to heal. You might have some pain for a long time, and some pain is okay. It's how you can tell that you're re-injuring yourself or things are going wrong. I need you to be able to come to me if your pain is getting way worse. But our goal is to keep that to break that crisis, to keep the pain tolerable, and to help you be functional. We have to talk about this with our patients. So back to Joey. Again, Joey's been taking that hydrocodone. It's not working. Here with gastroparesis, pain, anxiety for a couple of days. What can we do for Joey? Surprise, surprise, we're going to start with a lot of the same medications. So acetaminophen, add that NSAID. We're going to target that antiemetic. For Joey specifically, we know that there's a gastroparesis history. So metoclopramide, excellent choice for us because it's going to have that prokinetic property. So I would choose that, but you can choose any of the things on this list. Maybe if Joey also smokes marijuana, you're going to choose haloperidol. Super reasonable. So multi-targeted approach in our choice of antiemetic. Knowing that Joey had gastroparesis and underlying diabetes, there's a lot of neuropathic pain there. So we can add a dose of gabapentin, maybe 600 milligrams oral times 1. I'm going to reach for my IV lidocaine, 1.5 milligrams per kilogram, up to a max of 200 milligrams given on that pump or as a very slow push. And then I'm also going to remember that ketamine is another option for me. If all of that doesn't work, of course, you could add an opioid. But at that point, I'm admitting my patient for intractable pain because I just gave a million medicines and none of them worked, right? Maybe I'm adding a CT, et cetera. I did not mention this medication before, but it is another thing to remember when we're talking about belly pain, which is dicyclamine. So really common brand name on this one is Bentyl, but there are multiple of them. Dicyclamine can be given oral or intramuscular, not IV. It is an anticholinergic medication that relaxes the smooth muscle in the GI tract. This is an awesome medicine for patients who have more like cramping, diarrhea, bloating, and it's used a lot in irritable bowel syndrome. So sort of the opposite of gastroparesis, where everything is slow and not moving. IBS is the opposite. Everything's moving too much and crampy and bloaty, and we can slow it down by using dicyclomine. Excellent medication. Let's shift gears a little bit and do one more case. This is a 48-year-old female. Her name is Zena. She has a history of high blood pressure and migraines. Her blood pressure is well controlled on like lisinopril, but she's had 3 days of a progressive classic migraine for her. It feels like her normal migraines, but it won't go away. She hasn't been able to sleep. She's been really nauseous. She's got a fully normal neuro exam. She is not pregnant. Her vital signs are pretty reassuring, a little bit of high blood pressure, but nothing that impresses any of us in the ER, especially because she's in pain, but she feels terrible. And so what do? I want to mention here that specifically for migraines or for headaches, opioids have been proven to be a bad choice. Patients who get opioids in the ED have higher rates of rebound, more severe headache, and bounce back to the emergency department. So we actually have data that shows us that giving opioids is not the best answer. But we also know that migraines are really debilitating and they're awful for people. So you want to think about what we like to call the migraine cocktail. We're going to start with our 2 favorite medicines, acetaminophen. And since Zena's not pregnant, I didn't mention this before, but we don't do NSAIDs early in pregnancy, but she's not pregnant. So we're going to use acetaminophen and an NSAID. Make sure she's hydrated, right? Even a little bit of dehydration can cause patients to have worsening headache. So we're going to give her some hydration. We're going to pick the antiemetic of your choosing. Maybe if Zena is really tearful and she's uncomfortable and she hasn't been sleeping, right? I might pick something that's a little bit pro-sleep. So I like prochlorperazine in that setting. I love haloperidol in that setting, either of those. And then I'm going to go on the lower dosing end. So I can also add diphenhydramine to prevent those extrapyramidal side effects. Those 2 things together are really great. And then early adjuncts. So remember, if your patient had classic cluster headache sounding, that's not Zena, but if your patient did have cluster headaches, oxygen, high level oxygen for a little while is helpful. If they have a trigger point, if they've got like, oh my gosh, so much tension in the back of my head and my neck, maybe they have a cervical or upper trapezius trigger point that you could release with a trigger point injection. And then we also have this thing called the sphenopalatine ganglion block. If your patient has a frontal lateral headache or bilateral frontal, the sphenopalatine ganglion is a ganglion located right in the back of our nasopharynx, which is both parasympathetically and autonomically innervated. And the theory is that, we don't really know exactly what causes migraines, but one of the theories is that it could be from autonomic dysregulation. And the thought is that if you can numb that sphenopalatine ganglion, which happens to innervate this section of our scalp and of our head, that you can actually help relieve some of that pain. And in the right patient, these can be super, super helpful. We have a video posted in the chat for you, or you can follow this QR code to our friends at Academic Life and Emergency Medicine. They have a video showing how to do this procedure, but it's very simple. There are 3 ways to do it. One of them is you can actually wet a Q-tip with lidocaine and reach in there. I don't do this one because I think I would hate it if it was me. That's one way you can do it. The second way is you have the patient lay down, you do what's called the drip method. So you can actually put the lidocaine in a syringe, like on a little angiocath, and then you can kind of just drip it down the side of their nose. You're aiming for the side where their pain is. If it's bilateral, you can split the dose in between the nares. My favorite though, honestly, is I just pull in about a half a cc of 4% lidocaine or 1 cc of 2% lidocaine. I put an atomizer on the end of that syringe, and then I just divide the dosing between the 2 nares. You just put that atomizer right in their nose, you spray it back, That I think is the simplest method, but any of these works. Q-tip, drip method, or atomizer, and that's again for really frontal sounding headaches. So your first line is going to be that migraine cocktail, that headache cocktail: acetaminophen, NSAIDs, fluids, antiemetic of your choosing, plus minus maybe a trigger point, plus minus maybe sphenopalatine ganglion block. If that doesn't work, you can use magnesium IV. It's given slow over 60 minutes to piggyback. Magnesium is a smooth muscle relaxer. And the reason we like it is that when people have like that pulsating feeling, there is smooth muscle around our vessels. So it can kind of help to relax that pulsating feeling. Don't forget about dexamethasone, great pain medication and known to decrease bounce backs at 72 hours in patients who have migraines, which is a great option. And if that doesn't work, you can actually give a dose of 500 milligrams of valproic acid IV in 50 mLs of saline over about 15 or 20 minutes. So again, a piggyback run. Valproic acid is a medication that is used for intractable migraines by neurology. And so it's a really good option that we can use sometimes in the emergency department. What you'll notice is this is a very robust list of things you can use. And I didn't even list ketamine. It's still an option. You could try IV lidocaine. And then if none of that works, I'm getting a head CT or an MRI and admitting this patient to the hospital. I'm still not reaching for opioids. We shouldn't be needing opioids to treat true migraine or tension style headaches. So if all of this plus ketamine plus IV lidocaine is not working, rethink your approach. I want to make a very quick side note about procedural pain management. We are not going to deep dive into these, but there are options for nitrous oxide, right? So this is a medication, people used to call it laughing gas. It was kind of fell out of favor for a while because of a lot of staff abuse in hospitals, but this is a great option for procedural pain medication. Patients use it, they hold it up to themselves, they kind of fall asleep, they wake back up, they breathe it again, they fall asleep, they wake back up. So it's great in that way. It's out of your system in 60 seconds. So it's a great medication for patients to like get their procedure done and leave the hospital without having to stay for a lot of monitoring. They do these in dental clinics in the outpatient setting with no pulse ox, no monitor, no nothing. So super safe. And there's just a lot more to it than that. It's very simple, but if your hospital wants to do it, I encourage you to looking into bringing that back. And then, of course, regional nerve blocks. So don't forget about like directly numbing the thing that hurts when possible. And that could be a joint injection. That could be a hematoma block into a broken bone. It could be an iliofascial block for a hip fracture. I mean, if we can numb the thing that hurts, we should. So it's also a really good example. Occipital headaches, you can do a nerve block of your occipital nerves that come up the back of your head. Like there's lots of nerves that we can go for and directly numb those. I mentioned medication and non-medication. So don't forget that there is such a thing as non-medication adjuncts for pain, right? Hot pads, especially for like belly pain, heating pads can be helpful. Ice packs, where did you position that? Are you elevating the extremity that hurts or putting your head up if you're having a headache? Is your patient able to lay down and stretch their belly if their belly is hurting? Things like massage, relaxation, even laughter, distraction. This is a picture of what's called a finger labyrinth that patients can trace with their finger. It's like a little maze just to give their brain somewhere else to be other than just their pain. Music, meditation, imagery, aromatherapy. These things, they do work, and they may not work all by themselves, but they are really important to remember as a part of a holistic pain approach. I will tell you that if I have a patient in the ER who's in a lot of pain and they're there alone, often one of my first questions is there somebody that you love that you could call to come be here with you? Because even having someone to talk to keep you comfortable can be extremely, extremely helpful. What about your plan for discharge home? I mentioned that we need to talk more about education. We don't do enough education with our patients when it comes to pain management. We do a lot of talking about, blood thinners. You would never start them on a blood thinner and be like, good luck. We're going to talk about things like fall precautions, right? Or with insulin, we talk about things like hypoglycemic events or when to take it, why to take it, don't skip breakfast, all those kinds of things. But we don't tend to do that with pain. And so we want to start teaching our patients more. What do you do when you are in pain? And the first step is going to be preventing pain. How do you prevent pain? Whether it's stretch, physical therapy, icing things. Is it, taking care of your body, diet and exercise, whatever that's going to be. If they have underlying mental health issues, seeking therapy, getting those under control. And then when you're in mild pain, what do you do? And the answer is acetaminophen, NSAIDs, again, those non-medication based treatments like hot, cold, stretch, exercise, hydration, distraction, whatever that's going to be. And then if you're in moderate pain, you're going to do steps 1 and 2, and maybe there's an added treatment that you've prescribed for them. Is it dicyclomine for their belly cramping? Is it, a dose of gabapentin for neuropathic pain? What is it? All these things, lidocaine patches, etc. And then for severe breakthrough pain, that is when we might include opioids, which are not meant to be something that we do every single day, right? It's meant to be for true, I cannot sleep, I'm in such severe pain, I can't walk, I can't, function. And that education needs to be done with our patients. And please do not just prescribe tramadol as a cop-out. This is not a great medication. It doesn't tend to work very well for pain. It causes young people to have seizures. Like it's also a mu receptor agonist. So please just don't be the kind of person that kids yourself and thinks that you're saving an opioid prescription by picking tramadol. Please just don't do it. That's not the right solution. We can do better. We can do way, way better. I know we're going a little over on time. There's a lot of material here, but I do want to take one beat to talk about pain control in the setting of medication for opioid use disorder. These are the 2 detailed protocols we have available for you on our website. One is a bit targeted toward the ER and critical care settings. One is targeted toward med-surg units, but they're really similar. I encourage you to get a copy of it. Make sure that you've distributed it to all your ED teams and all your inpatient providers so that they feel comfortable. But the principles are going to be the same. And the main take-home messages I want you to hear are, number 1, do not stop the patient's MAT. Do not stop their bupe. Do not stop their methadone. We keep our patients on the treatment. It's the same as you would for any other home medication, whether it's blood pressure, insulin, whatever, like keep the patient on their medicine. However, for buprenorphine specifically, the rise and fall of the analgesic effects are shorter than the OUD treatment. So you can give the dose once a day to prevent withdrawal and cravings, but for pain, it kind of rises and falls more on like a 4 to 6 hour. So you can divide up their normal 24-hour dose into smaller, more regular doses to help with better pain control and continue to protect them from opioid withdrawal and cravings. Okay, so as long as that overall 24-hour is the same or higher, you're not going to hurt them in that sense. And then you can go up on the bupe dose. So if you divide it up into, say, like, you had 16 milligrams a day and you make it 4 milligrams 4 times a day, you can go up on those. You can make it 6 milligrams 4 times a day. So you can raise up those bupe doses if needed. And then do not forget your multimodal analgesia, all the other medications that we have reviewed today. So again, for buprenorphine specifically, do not stop the bupe. Use your multimodal analgesia. Consider dividing the 24-hour bupe dose into more frequent doses. I recommend at least 3, if not 4 times a day, dividing it up, and you can go up on that dose, right? You can increase it. You can use a full agonist opioid on top, but give your bupe first, right? So in case the patient has missed their bupe that day, make sure they get the buprenorphine in their body first. You can go up on that buprenorphine dose. If that doesn't work, yes, you can give morphine, hydromorphone, fentanyl, whatever on top of that, but don't be surprised if you have to give a higher dose. The reason you can do that is that buprenorphine has a stronger affinity for the receptor, for the mu receptor. It's not going to let go. So you can give the higher doses of full agonist opioid to see if that helps with their pain. And just really important, do not be afraid to treat our patients' pain. That's one of the most common reasons patients with substance use leave against medical advice, is that we don't actually address their pain. With methadone, the principles are really similar. So do not stop their methadone. Use multimodal analgesia. You can use a full agonist on top of it. Just make sure that you're watching for actual respiratory depression and sedation, right? So that emphasizes and underscores the importance of the multimodal approach, using all these other ways that we can for pain, but don't be afraid to treat the patient's pain. There is something else called microdosing, or people call it cross tapering. We have an entire lecture devoted to this. Invite you to go watch if you're interested, but this is the protocol. And the basic gist is that what you do is you can continue patients on full agonists. So say somebody with opioid use disorder comes in after trauma and they're going to be admitted to the hospital, and you're giving them, morphine, hydromorphone, fentanyl, whatever for their pain, but they also have underlying OUD. You can start very low doses of bupe while you're giving the full agonist doses for pain control, and then slowly increasing, titrating up those bupe doses, and then eventually coming down on the full agonist doses to elegantly start them on treatment and control their pain while they're in the hospital without precipitating withdrawal. Here's an example of what that regimen might look like. It's all here in morphine dosing, because you can always do morphine equivalent math to pick whichever opioid agonist that you're looking for. But here, for example, you start low dose bupe initiation day 1 as bupe 0.5 milligrams. So teeny tiny doses. Normal bupe doses are like 16 milligrams, right? That's our normal doses of bupe. So this is a teeny tiny little dose, and you're slowly increasing it over time to titrate it up without precipitating withdrawal, but getting our patients into treatment. And when you do that, this is kind of what happens, is that slowly the plasma concentration of buprenorphine rises to the point that it gets to a therapeutic level. And then the patient can, again, elegantly be discharged with that amazing treatment in place already. We'll wrap up with one final case to talk about how that goes. This is Tony. Tony is 40 years old. He has a history of opioid use disorder. He's been on buprenorphine 8 milligrams twice a day, which is a total of 16 milligrams daily, for like over a year. And he's doing great on it. And he has a wonderful life. And he actually drives for Uber Eats, is his job. And today he was in a car accident and he broke his tibia. And it's a tibial plateau. He's in a lot of pain and he's going to need surgery. So he's being admitted to the hospital. What do we do about Tony's pain? The answer is we continue Tony's buprenorphine. So remember, Tony was on a total of 16 milligrams daily. We can make that 4 milligrams of buprenorphine 4 times a day. I could also go up on that. I could make it 6 milligrams 4 times a day, or 8 milligrams 4 times a day. I'm going to add scheduled, not when he wants it, scheduled acetaminophen, a gram every 6 hours. I'm going to add my NSAIDs scheduled as well. I'm going to call my ED doc, my anesthesiologist, whoever I can, to talk about getting a nerve block, right? Tibia. Is there a way for us to just block the leg, to do an iliofascial block or something, so that he doesn't have to feel it at all, which would be the best way that we could do pain control, especially perioperatively. And I'm going to leave a hydromorphone as needed order in there for when he has breakthrough pain, because I'm not afraid to give him extra opioids for that. I'm going to think about my adjuncts, like elevating his leg, making sure that it's positioned, splinting it as soon as possible in the emergency department, getting traction on there if that's what ortho wants to do at all, making sure that we're getting surgery in the next 24 hours. And then if Tony's alone, can he get somebody to come keep him company? Does he have an iPad or something to watch, videos on a tablet? Does he have a coloring book? Whatever, something to help keep Tony's pain under control. And if I'm really not sure what to do, what you can absolutely do is call the substance use warm line. So remember, this is a hotline, or warm line rather, that's available to us. It's kind of banker's hours, which doesn't always help in the emergency department, but is a great opportunity for surgeons, hospitalists, inpatient clinicians to call and get advice for any of these more complex patients. Please give this phone number a call. It is free. If you leave a voicemail, they'll call you back within 24 hours, and they can be an awesome resource to you if you have a patient like that. And if you forget everything that I just said, you can see all those protocols and a recording of this lecture on our resources page at bridge2treatment.org. We invite you to go there. And then if you want this webinar for CME or any others just like it, we invite you to join our California Bridge Academy. Again, free, available CME for doctors, PAs, NPs, also and also navigators to get you those CMEs or those CEUs for free in Bridge style with lots of other topics just like this one. And if you want to reach out to me or our Bridge team, I invite you to do so. Here's my email, and you can reach at that info@bridge2treatment.org. So I will just quickly scan. I know we're over time, but I saw a couple of questions popping in here. So thank all of you so much for being here. Yeah, there's a comment in here about like how the DSM classifies substance use disorder. I agree that it's classified differently, and that's why we don't always think about it as being a chronic disease, but I appreciate the call out. So it's important for us to get out there and educate our colleagues in that way. And yes, when patients have underlying behavioral health issues, I mentioned that really important to include a solid treatment plan for their behavioral health as well as their chronic pain. Those things are directly related. And so we really want to make sure that we're attacking those. And yeah, treating the whole person, thinking about the sources of their pain and where that's coming from. I love that comment. Yes, I see we have a patient that joined us, and I so appreciate you offering this story that you have a history of chronic pain, and it's really hard to talk to doctors about it in pain management because people think like you're pain seeking, and I fully understand that. So I want to emphasize to all of us on this call, that's why we're here, right? It's to learn how to treat pain and have these conversations really, really openly with our patients to figure out what works well for them and be able to express our concerns, but also achieving the same goals. So I appreciate all of you for being here. And as always, just thank you all so much for everything that you're doing to help us to save lives and to help our patients live well. We'll see you next time.